Welcome to The Community Table, a discussion series about real life with diabetes. Community Table is presented to you by the JDRF-Beyond Type 1 Alliance and made possible with support from Abbott, Lilly, Prevention Bio, a Sanofi company, and Dexcom. Hey everyone, and welcome to a very special National Diabetes Awareness Month Community Table. DiabetesRX, Bridging Equity Gaps and Igniting Hope. I'm Tiana Cooks, Senior Community Manager at Beyond Type 1, where our mission is to help people with diabetes stay alive and thrive. This community table is a monthly series where we have unfiltered and honest conversations about life with diabetes. First, I am thrilled to introduce our incredible panel of partners. With us today, we have Dr. Rosendo Collazo, who serves as Epic Physician Champion at Health Choice Network. We also have Crystal Lucille from the National Association of Hispanic Nurses, who has served as a bilingual and bicultural public health nurse with the San Francisco Bay Area. We also have Dr. Monica Gomberg. Dr. Gomberg is Vice President of Clinical Care and Board Certified Endocrinologist at Blue Circle Health, specializing in Type 1 diabetes care. And lastly, we have Dr. Brittany Bergman. She is a pediatric endocrinologist and physician scientist at the University of Florida and represents the American Academy of Pediatrics Florida chapter. Thank you all so much for joining us. We're so excited and honored to have you as a part of this special community table event. So my first question, Dr. Brittany and Dr. Ross, I would love to know what the most common signs and symptoms that you have seen in your respective communities prior to diagnosis has been.
Yeah, I'll start with that one. So I, a big part of my practice is seeing kids with diabetes, and diabetes is a problem of insulin, and insulin is a hormone that helps the body to move glucose, which is a kind of sugar, from the bloodstream into the rest of the body to be able to use it to fuel your muscles and have energy. And so with diabetes, insulin either doesn't work properly or there isn't enough of it. And so that sugar stays in your blood, but it has to come out somehow. And so you end up urinating the sugar out, and it pulls water with it. And so a lot of my patients described to me that they were very, very thirsty and also just had to go to the bathroom like many, many, many times a day before they came in. I had a coworker who said like within a 45-minute trip one time, she had to pull over at a gas station 3 different times to both take a bathroom break and buy more water, just before she was diagnosed with diabetes. And so that is something that I hear a lot. It's just, peeing a lot and drinking a lot. Your body also thinks that it's starving when you have diabetes because you can't use that sugar as fuel. And so you break down fat because that's your other energy source that your body's able to use. And so people will lose weight for no apparent reason, like, we'll lose a whole lot of weight. And then just feel really tired and kind of crummy because, you're dehydrated, your body thinks it's starving, so you have really low energy levels and just feeling really tired and have headaches and those sorts of symptoms. And then eventually, things can get really serious where there's a byproduct of burning fat called ketones, and that can build up in your bloodstream. And, it does really bad things to how your body functions. And so you can start having vomiting and end up needing to be in the hospital with diabetic ketoacidosis. So things can, get really serious, after some time of having these symptoms.
So I'll just add to that, Brittany. That was an excellent overview. That in my world of adult medicine, and therefore primarily type 2 diabetes and everything that comes before then, the most common symptom leading up to the diagnosis is nothing. It's the lack of symptoms. And that's part of the problem. Even though that is changing, the awareness is changing. And I think that's because of this slow moving, it's like a slow moving train that starts off very slowly, with this process of, as you explained, insulin resistance, and then a relative insulin deficiency that develops over time, that you can have. I recall from my residency days in internal medicine at Jackson Memorial Hospital, where we would get patients that come in with a hyperosmolar state or DKA, type 2 diabetics, who've been walking around for God knows how long with blood sugars of 300, 400, 500, and in what would appear to be a steady state. But in reality, they have this slow breakdown of their processes, what we call a catabolic state, where you're, basically consuming fat, and you may not, that weight loss may be subtle, such as what we see in elderly patients that have comorbidities. There's a lot of patients that we would just ignore that or just overlook it. But these people are walking around with very high numbers, and all it takes is one incident, whether it be, let's say, a bad car crash or an acute coronary event, and next thing you know, everything just flies off the handle. And these people end up on insulin therapy, at least at the beginning. That was the history of how I experienced diabetes as a resident training in medicine. But in reality, in the day-to-day practice, it's about not seeing anything. So it's about being proactive and looking for these subtle things, not just in terms of symptoms, but also in terms of risk factors like family history, a relatively young female that may be showing signs of polycystic ovary, things like that we need to be aware of. One of the things that's greatly overlooked as an early sign is, for example, distal symmetrical polyneuropathy, which is a complication of diabetes, but can be seen well in advance in some people that have been sitting with this process for maybe, who knows, how many years, right? And it's the vibratory sensation that precedes, the light touch loss. So I would put a vibrating tune fork on everybody. It's like, what are you doing? I would just do it on everybody, because you never know when you're going to back into this diagnosis.
Thank you both. I think you bring up some incredibly important points. And on that note, I was just going to ask, what in addressing undiagnosed type 2 diabetes in the population, what screening opportunities do you see most effective?
Okay, yeah, I love this question because it is one of my favorite topics when discussing diabetes with clinicians and with medical students, and that is, how do we improve this process of diagnosing diabetes? So if we level set, we're talking about 1 in 10 adults have diabetes. We're talking millions and millions of people, and probably 20-25% of them don't even know they have diabetes. These are the undiagnosed diabetics. So when we take this and say, well, prediabetes, this is not a different disease. This is just part of the spectrum. We're talking now 1 in 3 Americans, and probably, 3/4 of them don't even know that they have this. So it's our job, when we look at this epidemic, and hand in hand with obesity, that nearly half the population has obesity, the downstream effects of this in terms of secondary disease, whether it be diabetes, whether it be cardiovascular disease, is in the hundreds of billions of dollars to the healthcare system. So we have to come up with better strategies, and I think we're getting there. But I think some of the how would you say it, the gold standards of screening processes, such as NCQA, United States Preventive Service Task Force, need to stay at the cutting edge of this. So if you look at USPSTF, their recommendation is for screening everybody 35 years of age to 70 years of age, right, who are overweight or obesity, right? And I'm here to tell you, I believe we should be screening everybody. And the reason is because, first of all, these scenarios apply to younger patients, right? And there are other patients that don't manifest these typical entry points. And so for me, the way I always teach things is, let's just screen everybody. And there's so many accessible. When you look at what a good screening tool is, well, diabetes is full of available and readily accessible screening tools. And we need to refocus our quality measures. So, like, for example, in NCQA and in the federally qualified health centers follow the UDS measures, right? Well, these measures have one measure for diabetes. It's the poor control measure with a diabetes greater than 9. Well, who thinks that greater than not that 8.9 is acceptable? It's not acceptable, right? So and it's on the reactive end of what a measure should be. To me, it should be proactive. We should have measures that say, how many people do you screen for diabetes? And you can apply risk factors if you want for that. And that then opens the door for having a multidisciplinary approach to doing this so that it's proactive. It can be done by anybody in a healthcare team, whether it be the dentist or the behavioral health provider or the clinical support staff. I was just talking to Brittany about the Epic system that we both use, which allows for embedding clinical data into the columns of your scheduler. And so if you develop let's say a standing order policy for clinical support staff that have their configured columns on their scheduler following multiple doctors, that shows the BMI of the patient, that shows the last A1C value, that shows the last A1C date, they can be going to town screening people with POC A1Cs left and right. And if we do that, we're not only going to diminish this problem of undiagnosed diabetes, but we're also going to start the process of avoiding what we call treatment inertia, where things just don't happen. And when they do, it's 6 months later. This is the way this should be done. We should have registries, not just for diabetes. We should have registries for people at risk for diabetes.
So my question for you based off of all the information you gave, have you noticed any barriers or access barriers when people are trying to get screened for type 1 or type 2?
I mean, I'll just say real quick that in the world of federally qualified health centers, the whole mindset, the whole priority of FQHCs is to break down barriers to access to care. And so many of our health centers have disproportionate populations of treating people that are uninsured. I was the CMO of a healthcare for the homeless program, where 95% of our patients were uninsured. And so I've not experienced that, but I know that it's out there. I don't know if Brittany has a different experience.
Yeah, I think one important thing is realizing a lot of the population is not plugged into the healthcare system on a routine basis, and so trying to get to those people can be really challenging. There was a study I just read recently where they did screenings in barber shops, and 9% of the people that they screened who said, part of the qualifying to be in the screening was that you don't have diabetes, but 9% of those people actually did have diabetes and just didn't know it. The issue with those kind of screening programs, though, is once you actually identify that someone has diabetes, how do you then get them plugged in to the healthcare system? Because you can't just tell them, oh, well, you have diabetes, good luck. You really need to be able to plug them in. So I think we have to be thoughtful about it. When we do community screenings, we can't just leave people hanging with no kind of follow-up step for how to then get care. But we are, missing people who aren't in the healthcare system. And then type 1 diabetes screening is just a whole different ball game that we're just now kind of getting going on type 1 diabetes screening. There aren't specific guidelines right now for who to screen for type 1 diabetes, but there are quite a few places that are actually doing universal screening of children for type 1 diabetes. It's not universal in the United States yet, but we're slowly moving that way. And that's going to be just building a whole infrastructure for how to do this, how to get people followed up, what the next steps are. So it's an exciting time in type 1 diabetes screening, but we're kind of just getting things going there. But definitely, if you have a first degree relative with type 1 diabetes, I for sure would recommend you to get screened. And there's some great opportunities to do that. One is through, it's called Type 1 Diabetes TrialNet, but it's a research collaborative. So you can actually get screened through them. And then if you'd like to participate in a research study, that's also an option if you do end up positive. And then there's a couple other screening initiatives going on as well, that you can get plugged into.
Thank you. Yeah, I know T1D Detect, and I know there's so many. And And I think there's a lot of value, and I hope that we can move to the universal screening in children, but also in adults, because I see so many people like being misdiagnosed, or it's, now they're experiencing complications because it's been so long. And we want to avoid that as a whole. And then the other component is I do also see a lot of people who are misdiagnosed with either usually it's type 2, and then they find out they have LADA. And I just think that there should be, more opportunities for people across the board to like get screened, but for all diabetes, right? Not specifically like type 1.
Yeah. I actually, I think this is part of the, stuff we learned in med school isn't necessarily true later. So, in medical school, I think a lot of us learned like type 1 diabetes is a childhood disease, it's diagnosed as a child, adults don't really get it. I remember actually as a medical student seeing, a thin male adult, I think he was like 35, who just came in with an A1C of 8 and, peeing a lot, drinking a lot, kind of classic symptoms. And the family medicine doctor being like, well, this is a really weird type 2 case, but I guess, that must be what it is. And so now thinking back, I'm like, oh, you probably had type 1. And, people just didn't really think about that back then. But if you look at the studies, the rate of getting type 1 is actually steady, like throughout life. So it's not like there's this huge peak in childhood and then adults don't get it. It's actually decently steady, like where adults also get type 1. So I think we just have to change our mindset around type 1 and how it works. It does behave differently in adulthood, so it's a little bit slower typically when you get diagnosed as an adult. But it is kind of all part of the process of type 1 diabetes.
Yeah. No, thank you for just kind of explaining in more detail, because sometimes I forget, like, not everybody really understands how the whole process kind of works and how our bodies do tend to react, especially as we're older. Because LADA is a very common thing that I've been seeing a lot of diagnoses lately. So very important to also differentiate between the two. And I had one last question for you both, or Dr. Ross, if you want to take this one. I know you talked a little bit more about like, the federally qualified healthcare centers. I was just curious to know, like, what options do they have for mental health treatment for people with type 2 diabetes?
Well, I mean, that's a very difficult area, and because the when you just look at the bare bones of treatment for people that have psychosis, bipolar disorder, a lot of these medications are associated with promoting insulin resistance, weight gain, and I guess relative decrease in insulin secretion. And so we have the danger of creating diabetes where it may have been a seed in the soil waiting to blossom, right? And so we have to be very careful with that. And I think when we identify patients who have risk factors, one of the key things that we do in a federally qualified health center is we have, in the ideal state, an integrated care model where we do warm handoffs of patients to behavioral health and vice versa. And so it's important for that communication to be continued through the process of care via care coordinators, via the EMR communication tools, so that we can try to avoid as much as possible some of the classic drugs associated with that, such as Zyprexa and things like that, that may exacerbate a problem. But here's a perfect example of what I'm talking about. If I have a behavioral health person who's going to go on an atypical psychotic medication and they have risk factors, I'm going to want a registry for at-risk patients. And this registry via multidisciplinary approach is going to allow us to bring this patient in and screen them for diabetes if we don't have a choice in terms of what else we can do for them, and screen them for diabetes not on a regular basis, and not only screen them, but use education tools to let them know that this is a potential risk, but the benefit outweighs the risk. And so we have to use our non-pharmacologic strategies to try to do as much as possible to not even let that fire start.
You know, what's interesting, I actually manage our Beyond Type 2 app. And typically when I'm in the app, I do see a lot of individuals who are experiencing different, mental health struggles. And I think that you mentioned having more resources kind of up front. I don't think that people are equipped with the proper tools or education that they really need to successfully manage their disease. And I think that has a heavy impact on their mental being. So yeah, thank you for kind of walking us through what that should look like.
Yeah, I was just going to add, I don't know if everyone with diabetes is aware of it, but just having a chronic condition takes a toll. I mean, people know this obviously, but it takes a toll on your mental health to even just have a chronic condition. And that's normal, that's typical. And so we need to provide more resources for people. Definitely like, for example, in my clinic, we're really fortunate to actually have psychologists who, and a couple of them actually have type 1, which is great. But psychologists kind of embedded within the clinic. And we just make it kind of normalizing it, I think is important. Like when people are diagnosed, we just, say like, this is, your routine visit with the psychologist just to talk about how you're dealing with things, and, how things are going. And, not to stigmatize it, like it's just normal. Like you need to be able to talk to somebody about managing diabetes because it is a lot of stress. And, I think it's like up to a half of people with diabetes have diabetes distress, which is where you just kind of feel frustrated or overwhelmed by the disease. So it's so important to have that access.
Diabetes distress is so real. I feel like every couple months I'm like finding myself all like, this is overwhelming. Like I feel burnt out, and it's so important to seek help and to find a community. I think that's another big thing. If you can, hop into an app or a Facebook group, like wherever you can find other people that can relate. I think that is huge.
And I think part of the solution for that, part of the solution is to make sure that you have patient buy-in. And part of that and a lot of that is education to the patient, because I want my diabetic patients to know more about diabetes than half the people in the clinic, because the more they know, the more they are going to take charge in terms of self-management, in terms of going the extra mile to do the things that are going to put them in the right place.
We need more doctors like you. That's what we need.
Old ones.
You're wise. I don't think you're old. You got a lot of wisdom. Um, okay, so I want to quickly shift gears to talk a little bit more about the health disparities in diabetes management. So, Dr. Gomber, I know that at Blue Circle Health, you guys do work a lot in the community and really addressing the disparities that you've seen where you're at in Florida. So I would love to just know like how socioeconomic factors and access to healthcare contribute to disparities in diabetes management.
Thanks, Tiana. I think it's really important to talk about this. For patients who live with type 1 in underserved and under-resourced communities, we need to talk about some of these like nerdy statistics that are really important to understand. And so the average annual cost of someone living with type 1 diabetes is over $18,000 per year. $18,000. That's a massive cost. They also face 60% fewer physician visits per year and have a higher A1C of over 1%. They have a massive increase in the number of ER visits compared to those who are insured. And there's a 4 times greater mortality rate. And the last important point is that patients who live with type 1 in these communities, 25% of them are med reducing or delaying their meds, meaning they're decreasing the doses they have or skipping doses in order to scrape by to make their insulin last longer, thus resulting in the ER visit, in the decreased physician visits, in the increased cost of care. All of this is happening all the time in order to get by. And I think all of us in this room and beyond can agree that this is really unacceptable. And we can agree that we can do better. And we're all working to do better, both as healthcare providers and as a community for our patients. And so I think it's really important. In Blue Circle, we prioritize and we focus on telehealth. And telehealth is one thing that can really decrease some of the barriers to care for patients who can't access the healthcare system, whether it's due to transportation, to time, to childcare, to location. Endocrinologists like myself are scarce, and you might find one, but it might be an hour drive away and there's a 6-month wait time. And that's really at best, right? Like at worst, they don't even take your insurance, or they require insurance that you don't even have. And what good is that? That's not going to help you. And so we need to really work on taking these barriers away for our patients and get them really the well-deserved assistance that they need, and really meeting their basic needs. And insulin is a basic need. It is a basic need for all of us. And so we need to partner with the patients. So if we take telehealth in specific, maybe it's during their lunch hour. Maybe it's while they're rocking their baby on their hip and making dinner for their toddler. Let's meet them where they're at. We can be on the phone with them. We can be on a Zoom call. We can have their appointment and meet them where they are in a time and place that's good for them. So we can get closer to our patients, serve them where they need to be. We acknowledge that really telehealth doesn't solve everything, but it's a really big step in the right direction. And that, combined with many other things, can help decrease these barriers for our patients. And that's kind of where we're at with that.
Yeah. I did a telehealth appointment before, and it was actually really simple. I think, it is definitely something we had to get familiar with during COVID, but proves to be very beneficial. So, yeah, I love that your guys' model and how you are able to kind of meet people where they're at. That's huge. And I know we were also talking about like cultural competency and community outreach programs and improving diabetes education and management in underserved communities. So would you mind just addressing that?
So really there's a distrust. We have to face that. There's a distrust of medicine and healthcare providers among communities and among underserved communities. And that's earned, sadly. And I think a lot of us work to fight that, and a lot of us do better than that. But it exists, and we need to acknowledge it. And that's one reason why Blue Circle, we hire coaches, peer support coaches with similar cultural backgrounds with the disease that our patients have, that often live in the same neighborhoods that they live in. It's also why we partner with the FQHCs that Dr. Ross was referring to and talking a lot about. And that's where our patients get their primary care in their own community. And we do that specifically with the intention to really build untrusted relationships. We can't walk in and say that we want to treat your diabetes care, and they don't know me from the person next to me. But they know and they trust their doctor that they've been seeing for years. If their doctor knows and trusts us, then we have a leg to stand on to say we're here and we're working together with the patient. So meeting them where they are, not only in their medical journey, but in their life and where they call home. And if we can't build that trust, we don't have that mutual understanding. So we need to really get into the communities that we serve, find out that what's critical and what's important to them, and also to refer back to the places in the community so we can all be a part of the journey together and really work together to get the patient what they need from multiple aspects in their life.
Yeah, that's a huge component to it. I was just telling someone the other day about a recent experience I had with my grandma, who was diagnosed with type 2 diabetes, and her doctor had prescribed her a CGM, but she didn't know how to put it on. And so she was like not using it. And I'm like, oh, this will, it's very beneficial for you to have this on so you can see how your blood sugar's like reacting to different meals and exercise. And she's like, I just don't know how. So she was going into like a local pharmacy, I think at like a Walgreens or something, and the pharmacist was putting it on for her. But you can't do that forever. So I was like, you really just need to find, resources in the communities, just like you said, but also if there are ways to educate people, if they could hop on a telehealth call and ask a question like, hey, how can I put the CGM on? That would really alleviate a lot of, the unnecessary stress that is put on them to figure it out, right?
Exactly. And it's really important, in you saying that she found the pharmacist who was able to teach her. Step one is even knowing to ask the pharmacist. Like, how do you know that the pharmacist can teach you that? And some pharmacists may not be able to teach you that. And so, like, getting that education out there of like who to turn to. And if it's not the doctor, like, because it doesn't have to be, who are these other people that can be there for you and help you with that?
Right. But I will say the codependency part too is also kind of concerning because she didn't know how to do it without them. So when I went and saw her, I was like, okay, let me show you how to do this so that in the future you can eventually just do it by yourself. So you're right. I think there's definitely a um, kind of centered approach to educating people on those things. And I just had one more question for you just about case studies. Would you mind sharing a case study where cross-discipline collaboration played a pivotal role in improving health outcomes for any patients that you've seen with type 1 diabetes?
That's only the best part of my like job in my life. So I would be more than thrilled to share a case with you, and I can talk to you for the next 2 hours, but I promise I won't. Um, the person that comes to mind, really, she's a very brave, kind, driven mom, wife, woman who was diagnosed with type 1 many, many years ago. And per her report, she never really understood the disease, never understood how to treat it, and felt overwhelmed and felt frustrated, as many people do. And she faced very frequently recurring episodes of DKA throughout her life, wound up in the ER many times. At one point, she was saying every month. And she had very like well-founded fears of doing things in her life due to diabetes, due to what happens when I go low, what happens if I go high, what will happen if I do X, Y, and Z. And so she wanted to work with us at Blue Circle because she wanted, in her words, to see the light at the end of the tunnel, because she could not see that light. She felt despair constantly when thinking about diabetes. And as you know, you think about diabetes throughout the day. It's not an occasional thing. So she started seeing one of our peer support coaches that I was referring to earlier, and they were able to share their life experiences. And she was able to realize that she wasn't alone, that these episodes of DK happened to our coaches too, and that she faced very similar circumstances in her life that made her feel like, okay, I'm not the only person who deals with this. And there was a lot of shame around that for her. So that support coach helped her in a lot of ways. That support coach also connected her to our CDCES and RD, Sherry. Her name's Sherry. She also lives with type 1 diabetes, and she was able to provide reassurance, guidance, and really the necessary educational support that she was never provided in her life. To really, the most important thing is to feel confident in the choices that she made. You were just talking about that, Tiana, like that empowerment and that confidence to know how to manage things yourself. That's really what this is about. And that's what our educator was able to do. Our clinical team, which consists of myself as well as a nurse practitioner who's incredible, and she also lives with type 1 diabetes, we were able to talk to her and make some like mutual medical decisions together. We were able to prescribe her medication that she needed, all for free to her through our financial assistance program. That also included a CGM, which allowed her to make some new decisions in her life. But in all of that too was trying to work through her medical distrust and her distrust of the system that existed up until this point in her life. So I want to talk for a second, though, is the CGM. So we prescribed her a CGM. And right as we were saying, it's easy to prescribe a CGM and say, I'll see you at your appointment in 3 months. Good luck with that. But as we know, there's so much that goes into that. And for this patient in particular, she had a lot of concerns. Like, for example, the first thing that came up is she put the CGM on, and the next day she woke up with really significant arm pain. And she thought, oh my God, like, is it the CGM? Like, something's severely wrong with this. Is there a needle in my arm? Is it deep in my, like, no one was able to, she didn't understand the concept of that because no one taught it to her before. She didn't know, was she having a heart attack? She didn't know, did she sleep wrong? All of these questions and concerns were going through her head, and we were there to talk through that with her. The other part of a CGM, obviously, is you put it on and now you see everything. You see all your sugars. And so she put it on and she ate the same lunch that she had the day before, but now her sugar was going up, and it was 250 and it was 300. And she's like, oh my God, what's happening? What do I do? I'm in a panic. This didn't happen before. I don't think, at least, but I didn't know because I didn't have a CGM and I feel fine, but wait, I'm panicking. So maybe I don't feel fine. Am I going into DKA? What do I do? There's this overwhelming amount of knowledge that comes with having a CGM that takes a lot of really important guidance and education on to understand what to do in these processes. It's not an easy, just now you know, and go about your life. And so there was that. And then, fast forward to 14 days later, she had the Libre. So 14 days later, I don't know how to take this off. Like, what if I take it off wrong? What if I put the new one on wrong? Like, oh my gosh, like this is so overwhelming. And so there were so many parts of that. And for each one of those questions, we stood by her and were able to educate her on like, okay, here's what you do in this situation. And now do you have questions for the next time? And what was so empowering to her is this person who felt a lot of really like uncertainty in her life surrounding diabetes and a lot of fear and being scared of what each step might be. She actually went on a trip that she was planning around this time. And she messaged Sherry, our educator, and was just saying like, my blood sugar went well. Like I went through security, I went through the airport and everything went well. And there was so much pride behind that because she wasn't able to say that before. And now she had all this information. She was empowered with all these tools to say, I know what to do in this situation. I know how to pull it off if I need to. I know how to react if it gets up to this number. And so this cross collaboration really is what's so important and what's critical to us. And I think what really helps the patient so much as they face these day-to-day decisions. So our team really works by being like necessary parts to a greater whole. And we ebb and flow together and work with one another and pick up where the other left off. So it's been an honor to work with her in particular. And I appreciate you asking about her story, and thank you for letting me share it and taking that time to do it.
Thank you for sharing. Such a moving story, and again, just highlighting the importance of having that support system, someone who wants you to be like as successful as you should hopefully want to be. Like that partnership just takes the management to another level. And I personally understand people sometimes do have hesitancies because it can be scary, right? Like, I remember before I got on the insulin pump, I probably didn't get on it for months because I was like, I don't know, like, it's a lot of trust that I'm putting in technology. And then actually once I was able to talk to a healthcare provider, my all of my worries were reassured, and I was like, were put to ease, and I was like, okay, I think that's actually the best option for me, and this is why. So I like how when you were explaining your story, you also explained to her why the CGM was helpful for her and what data she'd be able to collect from that. And because of that, she started to feel more comfortable and confident in trying the technology. So thank you for sharing. And on that note, I think we're kind of shifting to talking about peer-to-peer support. And Crystal, I would just love to hear from you because I know you work with the National Association of Hispanic Nurses, and I'm sure you've had a lot of positive impact in the realm of peer-to-peer support. But in what ways can support groups and networks benefit individuals with diabetes?
Yeah, I've been an educator for a long time. And while my title and my role is educator, I really find that when patients are in a group, they are the best teachers for each other. Especially if the way that we did it at our hospital was that we had a rolling class. So you could jump in and start at group one, you can start at group four, but no matter where you were, someone had already been attending the classes before you, and a new person was always coming in. And I found that they were the best people to communicate to each other on side effects, risks. And they would often be so willing to share upon brand newly meeting each other, very personal stories, sometimes as warnings to say, hey, I got diagnosed 10 years ago and I didn't take care of myself. And I've had a foot amputation. Like, take this seriously and take care of yourself, prioritize that, do what you need to do. And so I think the classes help normalize a lot of fears, a lot of concerns and worries, especially around insulin, around medications, around needles, finger sticks. I think it's also helpful that participants can see people who are maybe doing better, maybe people who are not doing as well as they are, and to know that all of that is normal, that there are seasons of life where you might be doing so great, and there are seasons of life where you might be struggling. And being able to show up with everybody, no matter where they are, and know that everybody in the group is on their own journey, I think that can be really reassuring and motivating for patients. And then my favorite thing is that I often give a lot of time, both at the beginning and at the end of group classes and support group, for people to share contact information. Now we have so many options with social media, texting, WhatsApp groups, and I love that they connect with each other. And often you'll find people who work in similar types of roles. And in where I live in San Francisco, we have a large number of patients who are restaurant workers or child caregivers or medical caregivers, and so they'll often have similar type of work, similar schedules, and then they're able to connect with each other after work or talk about work, and form relationships. And I find that the difference it makes from one class to the next in their mood is really great. And I think mood is so important. When you feel good or you're looking forward or you feel hopeful, you're more likely to take care of yourself. And I think that these groups, support groups and classes, provide that, something that I may not be able to give as an educator, as the clinician, but that you can get from someone who's lived in your shoes and walked your journey.
That was like so cute because I feel like, we need community A, but then just the way that you connect your community. You said like offering them opportunity to get each other's phone numbers and to stay connected after the event is over or after your group is done. I think that is so important. And those relationships, they have changed so many lives. Just to have one friend that gets it, it makes such a difference. So thank you for what you're doing. And you just have such a warm, like friendly, welcoming spirit. So I just wanted to acknowledge that too. I'm like,
Oh,
where
thank
can I find you at? Like, do they have crystals everywhere? Because I want one.
I get that a lot.
um, it's a good thing.
Yeah.
And I know you were kind of mentioning some stories, but was curious if you had any specific examples that you'd like to share with us, just about how the support has positively impacted any of your patients or people that you've interacted with.
Yeah, so it's been interesting to be in diabetes and an educator in the last 5 years to see the transition from um, before COVID, before the pandemic, when telehealth was not really a well used resource, to now where we use it so often and we can engage patients so much more, especially for my community of patients that are shift workers that work nights. This is a way that they can get care. And so during the pandemic, we scrambled to switch over into telehealth mode and provide telehealth classes through Zoom. And I had one patient who had been coming regularly, and he also had shared with me that one of the support groups he used was the Overeaters Anonymous group, and how that had been very helpful for him because it provided structure in a meal plan for him that was low carb, that worked with his medication and with his diabetes. And another patient joined our group and they connected, and that he invited her to that group because that was something she had been looking for, and that became a relationship that they formed. And then they found support not only in each other but also in this other group. And I think that for that patient, she also struggled with depression, and so finding this group for our group classes for diabetes, and then finding this other support group to help her to learn some new skills, feel in community with other people struggling with food, that was like extra double support. And that was a big shift because I think, the thing I feel that the patients, and my hope is that what they get out of the group is that they're not alone, that they can ask for help. And even if they don't know what is going on, that they know that we are their healthcare team and we're here to help them out. And so I say this at my class, like, I don't care that you memorize or learn anything. My hope is that you just feel comfortable reaching out when you need help. And I think for my patients um, that is a big relief. And I find that because I'm not a physician, I also happen to be a really petite, young looking face. And so I don't think I'm very intimidating. And so I tell my coworkers, like, people tell me their secrets. Um, and they'll tell me, like, I'm actually not taking my insulin, and I told the doctor that I was, and I'm not. And then that's where we start a relationship, and say, like, okay, that's okay, like, tell me why, tell me more, like, what do you want to do? And people in the beautiful thing about the group is that other people share, like, yeah, I did that too because I was afraid, and I learned how to do it, and now I do my own injections, and I can show you, I can help you, you can watch me, and I can be on the phone with you when you're at home and you do your first one. That is, I think, the power of community and support. And I think for diabetes, you can't do this alone, whether you live with your family or you live alone. It really, when you have a chronic disease, it's important to have support and to find it. And for anyone who doesn't know how to get into a group, the diabetes.org webpage has listings of that, and your provider will probably know about who to connect to as well.
Thank you. Great resources, and also really enjoy just learning more about the way you've created such a safe place for your patients to feel comfortable sharing some things that maybe they weren't, going to share with their doctor. And yeah, I think that having those relationships are incredibly impactful. I personally, like, I tell my doctor a lot of things, and it's been really nice because for a long time I was very scared to do that. But we've built a relationship where, like, we trust each other. So I think building that trust with the patients is huge. And that way, when they do feel like they need to reach out, like, I can't do this anymore, I'm feeling burnt out. It's never going to be something that brings fear or anxiety onto them. Rather, it's more of like okay, I can confide in this person. Like, this is great. So yeah, thank you for sharing that. And community, I'm huge on community. I love being in, whether it's with the kids at events or if we're talking to adults, teenagers, everyone, there's a community for you. So it doesn't matter what age, what background, what you're struggling with, there are people who get it and would love to just welcome you into their community. Before we wrap up today, we would love to hear from one of our community members, Dex Gerald, who will be sharing with us some of the significant challenges that he's faced in managing diabetes and how he's been able to overcome them. So, Dex, it's all yours.
When I was misdiagnosed as a type 2 diabetic, the stigma I got, and it wasn't really so much on me, mostly because of my body type, but the stigma that some of my family members got or other people I know living with type 2 diabetes was that they caused their diagnosis, that they were lazy, that they didn't eat well. So in the type 2 stigma realm, it was always blame on the person. And now that I have been correctly diagnosed as a type 1 diabetic, there's not too much stigmas that I actually hear or see as a type 1 diabetic. I know within the community of diabetes, and I think this just comes from frustration as a person living with type 1 diabetes, that most of society knows about type 2 diabetes and not type 1. So a lot of those stigmas that type 2 go through gets pushed on people who are living with type 1 diabetes. Like, people always say, like, well, you look really fit or you look really healthy when I tell them that I live with diabetes. So I guess that's the only stigma that I really get as a type 1 and as a type 2.
Thank you all so much for joining us today for our National Diabetes Awareness Month webinar. We've covered a range of critical topics from understanding diagnosis and addressing disparities, highlighting the importance of peer-to-peer support, and hearing personal stories. Remember, diabetes awareness is a collective effort. It is by coming together and sharing knowledge that we can make a real difference. We hope that you leave the conversation better informed and inspired to make positive steps against the fight of diabetes. Join our See the Science Town Hall December 6th at 6 p.m. Eastern Time for a dynamic conversation where we will be highlighting the See the Science campaign and how you can get involved and raise awareness and learn how you can become an ambassador. You'll also get the latest facts and information on early screening with diabetes and learn about the free TrialNet program, which we talked about here a little bit today. And all registered participants who reside in the United States will receive posters and educational materials. But let's continue raising awareness, supporting one another, and working towards a better future for all. So thank you again, each and every one of you, for joining today. I am greatly appreciative of your time, your wisdom, and your insight. And I look forward to talking with you all soon. Thanks for listening to this episode of the Community Table, presented to you by the JDRF-Beyond Type 1 Alliance and made possible with support from our sponsors, Abbott, Lilly, Prevention Bio, a Sanofi company, and Dexcom.